Well, good afternoon, everyone. Thanks for coming, and for those joining online, thanks for being here. Hopefully, we'll have some time at the end of Mike's presentations for questions. So it's really a great honor to have Mike with us. We've been working with Mike for a few years. Actually, when he started, he was a fellow at Stanford, and we started doing some work with diabetes technologies in the hospital. And now Mike is an instructor. He did his residency at Baylor, then completed fellowship at Stanford, and then stayed on faculty. He got his scale 2 immediately after his appointment, and now he just got his K award, his K23, to continue his work on automated insulin delivery. He brings a lot of expertise in diabetes technologies. He recently published a paper in New England Journal, really nice review on digital health for diabetes. He's been working with swimmers using Omnipods and doing a lot of work, also epidemiological data. And I think what he's going to present to us is kind of looking into the future and how we're going to be managing patients with advanced diabetes technologies. So Mike, thanks so much for being here.
Thanks, Francisco. Thanks for coming. It's a big honor for me to be able to talk here. Like Francisco mentioned, I have known both him and Georgia actually just about since I started at Stanford, which occurred to me when I was putting these slides together. About 2 or 3 months after I started at Stanford, I started working with them. So it's been awesome. And I'm just going to talk a little bit about sort of a smattering of kind of where we're headed with some of the data, and then where we're headed with this. The slides advance. Okay, there we go. So I do have some disclosures. I've been fortunate to have some NIH funding the entire time I've been at Stanford. And I have done some consulting on inpatient-related work with Dexcom, which is worth acknowledging. So yeah, I'm going to talk background. I'm going to talk about this aiding pilot and feasibility trial, which I'm told you guys may not have heard about, so I thought I'd put that in here. Inpatient use of personal devices, creating infrastructure to support use in some future directions. So as any good, from a physician's perspective, as any good problem, comes from patient stories. And so I just wanted to start with that. So we have a 66-year-old woman with type 1 diabetes for 4 years, admitted to the hospital with non-displaced fracture. Her insulin pump was removed in favor of basal bolus, long and short-acting, multiple daily injections. She was found to have C. diff in the setting of diarrhea, so she had to go on isolation. She was very frustrated with the injections, lack of flexibility, meals being cold, and then she had a lot of fear about hypoglycemia. So even when the nurse would calculate her insulin dose, she'd say, "No, give me half." So you can imagine that's a challenge. She had been on an insulin pump for 6 years, historically had high A1Cs, and struggled with fear of hypoglycemia, as I kind of alluded to in the hospital. She started on an AID system, automated insulin delivery system, about 2 years prior. And with that AID system, her fear of hypoglycemia considerably lessened. She became comfortable with lower glucoses, and her A1Cs lowered in tandem with that. Okay, so she was, it doesn't really take an endocrinologist to see the difference here. Her finger stick glucoses and lab glucoses are there in blue and red dots. She gets put on the AID system after our services were consulted in endocrinology. However, she had to go to acute rehab, where her insurance wouldn't approve one that we could find that would help her, allow her to continue her pump system. So we moved her back to injections, using the pump to calculate those doses. And even still, you can see how challenging her diabetes was to manage. And this is type 1 diabetes, which is a lot different than type 2 diabetes in the hospital, and something that's actually quite undercharacterized. So there's been an explosion of diabetes technology revolutionizing outpatient diabetes care. This is just like the, I'm not going to go through all this, but this is just like the figure when I started fellowship, 10 to 15 minutes ago. This was a much shorter table. And you can see the FDA and CE marks just in the past couple of years have exploded. These are all the commercially available AID systems sort of globally right now. But meanwhile, little has changed in managing diabetes in the hospital. It's important, we recognize that, but it's limited with the standard basal bolus approach. One in three hospitalizations in the US involve type 1 or type 2 diabetes. We're likely all familiar with evidence showing hyperglycemia is associated with numerous adverse outcomes. Most prominently studied of which are sort of up here. There it goes. But we also have to, since our nice sugar trial, there's a recognized risk of iatrogenic hypoglycemia in the hospital, and we have to counterbalance our targets with the risk of hypoglycemia. Everyone at Emory, I'm sure, is familiar with the basal bolus approach since Guillermo Pierre's famous RABIT-2 trial, which sort of established that as the hospital standard. But there have been minimal advancements since, and we're still not achieving targets. Iatrogenic hospital hypoglycemia is still up to 30% of patients in type 2 diabetes. Diabetes management in the hospital presents unique challenges. There's variability in insulin sensitivity, nutrition intake, activity, timing mismatches between food and insulin, glucose tolerances since nice sugar. Targets were set conservatively, 140 to 180. Those have been progressively lowered in less acute patients, including non-ICU patients, to 100 to 180, but most of our hospitals, including Stanford, don't actually treat until patients are below 70. So 70 to 180 ends up being more of an acceptable glycemic range, but our target is 100 to 180. Diabetes management in the hospital uses considerable resources. Bedside nurses spend a huge amount of their time doing this, nurse managers, educators, inpatient diabetes educators, pharmacy, dedicated diabetes consult services, diabetes task force hospital committee. I was just talking to somebody who's on the task force at Midtown. And even still, cost benefits have been demonstrated with returns on investment on these teams. Up to 467% return, this was a few years back, more than $2 million annually in one system, likely due to reductions of length of stay, readmissions, incidence of glycemia-related complications. So I already mentioned that the rapid technologic advances in the outpatient have revolutionized diabetes treatment. So why have we not seen similar trends in the hospital? Well, one, early investigations were not particularly impressive. Management complexity and education requirements in a hospital is an entirely different beast. And then there's rapidity of change. So a hospital is a slow-moving infrastructural organism, and these things are changing very, very rapidly. Insulin pumps on their own have been studied. We call it manual or open loop when they're not communicating with the glucose monitor, glucose sensor. And they had highly variable outcomes, high incidence of hypoglycemia in studies and hyperglycemia, minimal, if any, difference with pumps between MDI. And then there was one small randomized trial, only 16 patients, but you can see the lowest mean glucose, blinded CGM, so no CGM, and basal bolus. So why use a pump? Well, interestingly, in the study, it showed hypoglycemia detection increase. So there were 7 events that were not, noted on fingerstick in that group. And then patients with unblinded CGM actually saw more reductions in hypoglycemia, which raised a lot of questions. So those questions sort of revolved around what's the utility of continuous glucose monitors. Pre-pandemic, there were probably about 5 studies in the ICU, 5 in non-ICU patients with older CGMs, mixed sensor accuracy, but there was still a lot of excitement about potential benefits of CGM in reducing hypoglycemia. The game change was COVID-19, as we all know. FDA, in a roundabout way, sort of issued an enforcement discretion, allowing CGMs without labeling for inpatient use. Many centers integrated these, and this led to a rapid expansion of interest in inpatient use of diabetes technologies. There were 4 RCTs looking at CGM in patients. On the left in red would be real-time CGM. On the right would be blinded CGM using the standard finger stick approach. And very disappointing. No difference in time in the so-called acceptable target range that I mentioned of 70 to 180. The RCTs, this is just a different representation of that data. You can see on the right, looking at time below range hypoglycemia. There was one study by Singh et al., which specifically included patients who were at risk for hypoglycemia that did see a significant decrease in the rates of hypoglycemia. But in the other studies, no difference. So the question is, why not? Unlike the outpatient, the inpatient environment may be less benefited by CGM-based biofeedback. I think it's worth considering that while a patient may be able to alert a nurse about impending hypoglycemia, using a CGM in the inpatient is far different than in the outpatient environment, particularly in terms of autonomy with insulin delivery and the capacity of hospital staff to actually make use of all the additional data they're getting from the CGM. So I'm not sure this is the end of it. I think probably all of us who manage diabetes in the hospital can think of more than a handful of cases of CGM-based near saves, but it'll be interesting to see. But perhaps also there's something to the study designs, and when you look at the supplemental data for or the protocols for the studies, the insulin management itself was not changed very much from how we manage insulin with finger
You
sticks.
compare, say, variability of glucose, inpatient versus outpatient on CGM, which is worse?
The variability of glucose for inpatient CGM versus outpatient CGM. I don't know that there has been much difference in variability.
One possibility is in inpatients, they're already high hyperglycemia, there is less variability, and therefore CGM fluctuations are not picked up to make a difference, maybe.
Oh, I see what you're saying. So they're in a, yeah, I mean, I guess it depends on the patient population. There is still quite a bit of variability with insulin use in the inpatient environment as well. I don't know off the top of my head what the coefficient of variation from those studies was, but I don't recall that it was significantly different. There was some in some of the automated studies later, but it's an interesting point though. So this led a group of us to be interested in this gap specifically that CGM data may be better utilized to affect glycemic outcomes with inpatient automated insulin delivery, which can be far more responsive than could ever be possible for hospital staff administering multiple daily injections. And so just briefly to consider this point, primary potential for AID could be based on it being adaptive and predictive, or having adaptive and predictive real-time adjustments requiring less input requirements for both physicians and nurses, adjusting to all these variable insulin needs that I kind of mentioned at the beginning, and then also potentially adjusting or accommodating some mismatches between bedside food delivery intake and the timing of insulin administration. There were hardly any data on this except for from one collaborative group in Europe who were working on a system now available in Europe as CAM APS. It was on the little table at the beginning. And they studied a closed loop version of the system, the HX, which is not commercially available, although CE marked, on hospitalized patients across a few randomized trials, which demonstrated pretty convincing superior glycemic control without increasing the risk of hypoglycemia. You can see their initial studies. The system was quite clunky, for lack of a better way to put it, but outpatient systems started that way too. So our group that I mentioned included investigators from Emory, which was actually our primary site, Stanford and the University of Virginia, and was coordinated by the James Center. This was the project that I began collaborating with Francisco and Georgia on at the beginning of my fellowship. And we saw very encouraging results in this study, including the time patients were able to stay in automated mode on their systems, time in range and time below range, which I'll show you just briefly. So to this end, we created a single-arm, multi-center feasibility trial to test a now commercially available AID system, the Omnipod 5, which we chose specifically because it seemed highly amenable to inpatient use with its capacity for remote management, such as bolusing, and the fact that it's disposable, it's relatively small and contained on the body. We initiated and used the system in until discharge or up to 10 days in 18 patients who had insulin requiring type 1 or type 2 diabetes and were admitted to non-ICU units. Primary endpoints included feasibility, measured by percent time in automated mode of the system, and then efficacy was percent time in that acceptable glucose range I mentioned of 70 to 180. The implementation did involve some considerable effort, including developing nurse protocols for training, CGM telemetry, monitoring, alarm response, accuracy validations, and bolusing of insulin, which the nurses did do. It took a lot of planning, and this was the study setup. So the devices all communicated via Bluetooth in the room, primarily managed by the bedside nurse, as I mentioned. However, we did test the ability to interact outside the room. For example, if the controller had to be moved outside the room for remote bolusing. The data wirelessly streamed to a secure cloud, which was used to provide glucose telemetry at the nursing unit via a CGM-specific application that was housed on a tablet and had alarms. And then also provided data to the study team with remote access to both CGM and insulin pump, insulin delivery data. So despite the small number of patients, I think we were able to enroll a fairly relevant heterogeneous cohort, mostly older adults, mostly male, 40% Black, African American, largely contributed from our population at Grady, which I think is actually a real strength of this study. Stage 1 obesity was, BMIs in that range. More than 50% had an income less than 100,000. The majority were on government-sponsored insurance. Most patients had type 2 diabetes, but 2 patients had type 1. They have long histories of diabetes, higher A1Cs, and then an important point is limited device experience. So 50% of the patients had never used a CGM, and none had ever used an insulin pump before they were started on this study. They had full dose insulin requirements, which I think is another important point. These are patients who really required active insulin management and were therefore at risk for all of the things that come along with that, not the least of which is hypoglycemia. And they had long hospital stays, more than a week often. Median was 12 days. A good diversity of admission diagnoses were represented. So these were acute patients, they were real acute conditions requiring hospitalizations. And I mentioned the primary endpoint. So 16 of the 18 patients ultimately met the criteria with at least 48 hours of data for analysis. In terms of feasibility, the median percent time in automated mode was 95%. So almost all the patients were able to stay in automated insulin delivery for the duration of their study participation. In terms of efficacy, there was 68% time in that optimal glucose range, near zero hypoglycemia, and only about 7% of the time was spent above 250 mg per DL. Looking at the aggregated glucose data on top, you can see the interquartile range primarily stays within the time and range bounds and stays quite clear of hypoglycemia throughout the day. Even excursions between the 5th and 95th, I don't know if you can see that very well, 5th and 95th percentiles in the light pink, it stays quite clear. In the bottom, and the 24-hour insulin delivery trends show sort of the expected basal bolus pattern. So this is a hybrid closed loop system. You put the carbs in and it boluses the patient. There was lower insulin delivery overnight. A number with type 2 diabetes actually had prolonged overnight suspensions, which I think has other interesting implications. Importantly, you can see the system delivered sort of a broad range of insulin doses per meal, well beyond 40 units within an hour in some cases. So, I mean, these patients were getting insulin, just to reiterate that point, I guess. And again, the corresponding glucose excursions in the panel above are really quite limited. And I think that's kind of what, you know, to your point, the glycemic variability is likely much more limited in a system like this. And that is what borne out in those Avorka studies that I showed before. So we had 2 patients with type 1 diabetes, and this was actually one not from our site, but I like the figure because it's so, again, doesn't take an endocrinologist. And it's so, it's very striking. This is what it's like to manage type 1 diabetes with injections in the hospital. And this is why patients get frustrated. Glycemic variability is just a significant challenge for treating patients with type 1 diabetes. And you can see how much that was reduced on the system that was not designed for inpatient. So for the study, we needed a way to monitor the accuracy of the CGMs since insulin was being dosed based on this. We started designing it actually, you know, several years ago when there was considerably less data on CGM accuracy in the hospital. There was essentially no guidance on what was appropriate to this end. So we made some decisions as a group, which worked since the FDA ultimately approved the IDE. We needed it to be done in real time. So we did use point of care finger stick glucoses as the reference. And we used this amalgamated percent 2020 criteria that I believe was actually first reported by some individuals here, including Eileen Fultz, who is no longer here. But we had that as the basis. Essentially, it means that for reference glucoses above a certain amount, the CGM has to be within 20%. And for glucoses below a certain amount, it has to be within 20 milligrams per DL. And you can set that cut point. We set ours at 70 because that's the hypoglycemia threshold. But others have reported it at 100. We also set it up so that nurses could easily evaluate the accuracy when called for and leverage the EHR to that end where they got a simple output of yes or no, you can use the CGM or not. And I think that was a really important feature. You had to tell the nurses what to do with all that info. We had a sort of clear guidance on what that means, yes or no, built into the EHR. And then another important point that we included in our nurse training was when you could not validate. I think this is something that is potentially affects some of the CGM accuracy criteria out there in the inpatient, but the concept of fluid differences. So CGM is detecting interstitial fluid, finger sticks are blood. The concentrations do not equilibrate at the same rate. So if you're in a situation of rapid change, your glucoses are expected to be different. And that doesn't mean your sensor is inaccurate. So I think this was an important initial step in evaluating the feasibility. It highlighted the potential of AID systems, again, in the inpatient diabetes management. It demonstrated, I think importantly, that nursing staff could actually handle a lot of that, including the insulin delivery and this validation protocol. And it opened opportunities to design trials, which we've done now, that emphasize the implementation aspects. I got to present this at ATTD on behalf of our group. And it was the first time I had met a lot of these people in person after working with them for more than 2 years. So that was actually a lot of fun. And I just, I think, I guess Francisco and Georgia haven't presented this data. So I just wanted to give them a huge shout out for, Francisco was the overall PI for this. It was an awesome experience for me and working with them. And now it's published in DTT as of August or September, something like that. A lot more data in there. So AID has potential. Can we use it though? Well, maybe we are actually. I mentioned that diabetes device use has exploded in the ambulatory setting. So how about starting by identifying how much patients' personal devices are actually being used in the hospital during admissions. That aiding study just took an outpatient device and stuck it in the inpatient. So I looked at Stanford. Our insulin pump experience in the hospital is fairly extensive. Getting the data was tricky. We're quite aggressive about continuing devices whenever possible, and so are our patients, maybe even perhaps more so. So in 2022, we had more than 100 patients hospitalized or hospital encounters with longer than a day with insulin pump use. 2/3 of those patients had type 1 diabetes. On the right, I have some estimates for based on monthly census numbers, et cetera. But ultimately, 93% of patients presenting with an AID compatible system were using that automated mode in the hospital.
What's the cost of an AID system?
Depends on the AID system, right? So you have a major fork in the road in two different systems. So you have the type of system that we used, which is a disposable patch pump, where you dispose of it every 3 days. And then you have a system that you keep, you refill with insulin. It has a tube and it connects to your body. That one is on the order of $5,000-$6,000 investment. May not be super amenable to inpatient use. That's a point I'll make later. The AID system, I don't know what the actual out-of-pocket cost these days for the Omnipod 5 system is, but it's, you know, I think well under $1,000
Out of pocket.
out of pocket a month. So most insurances, especially for type 1 diabetes, are covering the majority of these systems with minimal copays.
The question is, what would it cost to lower the cost of the equipment? What would it take? What areas can be?
What would it cost to lower the cost of these things? Yeah, so I think that to some extent it has to do with the use, the prevalence of use of the devices, right? So initially, when only a few people were using them, they were much more expensive, harder to get a hold of. Stanford Hospital knows this very well because they accidentally threw out 2 Medtronic pumps and a tandem pump, and they had to buy those. So that that was a whole thing. But I think also, you know, that gets down to the business of the companies and the calculations they make. So if they see an opportunity wherein you can capture an inpatient market, that changes the dynamics of what they're going to charge for the system considerably. In the outpatient, I think there's a lot of pushes and advocacy for decreasing the cost. They are not distributed equitably in the US, let alone globally. Yeah, there's a million factors to that question. It's an important one though. Okay, so what about outside academia in the real world? Yeah, okay, so you know, at Emory, at Stanford, you guys use your fancy policies, but what happens in the real world with patients who are on these devices? This is like very fresh data. We did a survey asking patients exactly that. This is a direct to patient survey available in multiple languages. Criteria required hospitalization in the US within the past year with any form of diabetes and using CGM pump or an automated insulin delivery system at the time of that hospitalization. On a side note, distributing this survey was very challenging. And I do not feel like we got very good representation from patients in the US. So if people have experience with distributing these surveys in an unbiased way nationally, please let me know. It's not too late I pulled the data for ADA abstracts, but it's not too late for me to act on that. So I would appreciate that advice actually. Anyway, so here's what we did get. 258 patients, we got more than 500 responses, but after you clean the data for duplicates and exclusion criteria, ended up with 258.
How did you identify these people? This was a Stanford system or?
No, so we specifically didn't just do Stanford system. So it was distributed through a number of networks, Children with Diabetes, JDRF, T1DX, Beyond Type 1, Beyond Type 2, Facebook groups, cystic fibrosis systems, gestational diabetes, I was basically hustling all of social media as much as I could. Okay. So patients were mostly adults, mostly identified as female, overwhelmingly white, and with type 1 diabetes, and about a third were publicly insured. So essentially, we surveyed the online community of patients with type 1 diabetes, which is not necessarily what I want, because there's a lot of people that don't have type 1 that are using these devices, or anyway, we did get responses from 45 out of 50 US states. Just over half of those who provided the data were from urban or city hospitals, a third from suburban, and 7% from rural locations. There were many reasons for hospitalization, mostly for surgeries, diabetes-related problems, or infections, but there were a fair number of pregnancy-related, neurologic, heart and cardiovascular was a little lower than I had expected it to be, but anyway, despite the demographic limitations in the data, I think that the data itself is quite interesting. So 90% of those who reported use of CGM, so that was 252 people, used it during their hospitalization, and 73% used it for more than 90% of their stay. Non-AID pump use was far less in 2023. So there was only 37 people who were using a non-closed loop system, a non-automated system, of whom 87% used in the hospital, again, with most using it more than 90% of their stay. And then finally, for people who were using AID compatible systems, we specifically asked whether or not their device was used, but also whether the automated mode of their pump was used. And 78% of those who reported AID use at home used their system in the hospital, and 66% for more than 90% of their stay. So the main point is this is already happening in the real world. Personal AID systems for home use are being used in the hospitals across the US, and really no one has data on how well they're working. We also asked them just subjectively to rate how well their glucose was managed on a 5-point Likert scale. Too few patients were on the non-automated systems to really assess this, but for those in whom CGM or AID were used in the hospital, a significantly larger proportion agreed or strongly agreed with the statement, "My blood sugar was well controlled while I was in the hospital." So diabetes devices are being used inpatient. People seem to feel like they're working, and we should probably find out how well. Meanwhile, at Stanford, this is probably my favorite slide because you can't tell what the maybe intention is behind that. We're using devices, but there are issues. So right as we were sort of dovetailing with the aiding study that I mentioned before, we had a diabetes task force meeting, and it was brought to our attention that there were a lot of issues and conflicts with patients, between patients and nurses about CGM use. And patients, and these patients don't realize this, but they ended up advocating for the entire, like all of the patients admitted to the hospital by doing this, but they were refusing glucose sticks. Nursing was uncertain about whether they could use the CGM even to bolus an insulin pump. And patients are on AID systems. So you have this complex algorithm that's predicting a glucose horizon 60 minutes in the future that you're trying to affect, and you're taking a finger stick and, circumventing all of that by sticking it in the system. And then teams were having to place individual communication orders, physicians, every nurse, like, please don't page me again. It's okay for the patient to use their CGM. No guidance about how and where to document use, even with the communication orders. And we felt like patients were using CGM before this, but there were all these conflicts. I said this to somebody earlier today, but what is a nurse supposed to do? Like, do I not give the patient insulin, or do I just use the value that they have on their phone? They're not taking the finger stick. So we adapted the validation protocol I mentioned from aiding as a new protocol for our inpatient use, and initiated as a pilot through our diabetes task force in November of 2022. So this is what it looks like in the EHR. This may be familiar to some of y'all, but it's an example of how the validation output looks like. So the nurse puts in the finger stick, puts in the continuous glucose monitor, and hits file, and it comes out and says whether or not the CGM is accurate enough for use. So we actually got a lot of interesting accuracy data to think about from the aiding study. It's a little bit of a unique situation because we were actively managing the accuracy in real time. So it's not like a pure, oh, we compared two things to see if these CGMs were accurate. We were intervening on the accuracy with calibrations along the way. So from 597 matched pairs, again, with point of care as reference, so that's not a perfect value as a gold standard. We had an overall mean absolute relative difference, which is exactly what it sounds like, of 12.3%, including 26 calibrations, median of 1 per patient. So affecting the accuracy in real time. And you can see agreement criteria on the right. Again, that percent 2020 metric was the one we were using to say the CGM was accurate or not. So 83%, or 84%, excuse me, of the values said CGM could be used. And then there was a proportion that we could not, about 15%. Here's a Clark grid from that data. I'm not going to explain a Clark grid right now. For those of you who are familiar with it, here it is. But the important thing was that there were no missed instances of hypoglycemia. This is a very scary situation when you're automating insulin delivery. If the system doesn't know the glucose, or if the system thinks the glucose is normal or high and it's really low, then you can either maintain that low or drop it even lower. And then zone A plus B, which are the favorable areas to be, where it was 99.7% of values, which is pretty.
Did you monitor things like hypoglycemia or hypokalemia?
Hypokalemia? No, I don't think we did. I'm trying to remember if there was a patient who got hyperkalemia treatment with insulin. I think there might have been during the study, or that might have been a different experience I had. Now I'm forgetting, but no, we didn't measure hypokalemia. Here's what we ended up with. So this is Rachel, Anna, and Olivia. All of them worked for Epic IT. The thing about creating or implementing a protocol in the hospital as opposed to a research study is you have to think, how are you going to keep this going sustainability wise? And you have to make it very, very easy or nobody's going to care and it will get lost in the dust. So our idea with this was, let's make it easy enough for one of our house staff members from general surgery to order in the middle of the night when a patient's being admitted. And this is what we came up with. So we had a criteria for accuracy validation. We had essentially the provider selects the CGM and that's it. Everything else goes into the chart that's needed. Our frequency of accuracy validation requirements actually depends on which CGM you select and its perceived accuracy. So Libre 2 has a few more issues than Libre 3. So this one is going to get validated twice daily, whereas the Libre 3 would be once daily in the morning. We had use contraindications that were specific to clinical scenarios rather than units, so that this could be implemented hospital-wide, and then interfering substances, including best practice BPAs, were specific to the CGM. So if, whether it's mannitol or acetaminophen is going to show up in the chart, only if the applicable CGM was selected. Patients, this is very important from a hospital liability standpoint. There's a patient acknowledgement. It was very different if the hospital provides a device versus if the patient signs something that says, I prefer to use my own device in lieu of that, and I agree to a minimum number of finger sticks to make sure that this is accurate enough for use. And with this, we were able to actually implement a system by which we were dosing insulin for pumps and for injections off of CGMs. The other important thing was our diabetes educators were very fortunate to have a few in the inpatient, and they were automatically consulted. So the nurse would have somebody to communicate with if clarification was needed on documentation, those types of things. Implementing anything in the hospital is not a small challenge. I had a lot of fun picking out the icons for the challenges for each of these different committees. But it was approved. So we started it in November 2022, the pilot, and it was approved in May 2023. And I put a picture of Lois. She's one of our diabetes educators. She was really a champion for iterating back and forth and helping to move it through all these different policy committees. Okay, again, very, very fresh data. So since then, November 2022 to August 2023, what did this look like in real world use? So it was used in 135 patients. With demographics that are actually relatively representative of our hospital patient population out in the Bay Area, with 3/4 having English as their primary language, about half had type 2 diabetes, a third with type 1, and then there was representation from pancreatogenic diabetes and cystic fibrosis.
No GDM.
No GDM, because GDM is usually admitted to our pediatrics hospital. And then 30% were transplant recipients. There were 185 hospitalizations across those 135 patients using CGM. The vast majority were either using G6 or Libre 2 sensors. No surprising based on the timeline there. About a quarter were using automated insulin delivery, 15% on Control-IQ, 4% on Omnipod 5, and 4% on 670G or 770G. And that was surprising to me because literally in November I was on service and I had 2 patients on 780G, but you know, the data is what it is. And then mean hospitalization was about 8.7 days across this group. Okay, so a note about Clark grids. I put this up before, but I think it's important to mention here. This is sort of there are a number of grids that actually you can use. This is the one I find myself always gravitating toward because it gives you an assessment of what happens when the paired values do not align in terms of risk to the patient. So this zone A is, you know, our %20, 20 criteria. Outside of that is not technically accurate, but it's not going to lead to a lot of risk to the patient. Those are called our zone Bs. The zone D and E are the more danger zones, and particularly this left-sided zone D and E. This is the missed hypoglycemia scenario I mentioned. The other reason I put this up here is that green shaded area is what we aligned on as a hospital. The CGM must fall within that to be used. So this is a little bit more stringent actually than a lot of criteria, but even sitting out here in zone B, that means you're going to revert to point of care finger sticks until you're back in there. But partly it's because we were doing it only once a day in certain scenarios. So here are the results of that. I think they're quite striking. Again, they're from timed validations, mostly hopefully in times of limited glucose change. The mean absolute relative difference was 9.6 across all CGM types. There were a few in this zone D area that I mentioned is a little bit scary. Again, those were not used for insulin dosing when that occurred. And this is maybe even more interesting as you can look by different CGM types. So we had G6, G7, Libre 2, Libre 3, and Guardian 3. One thing that was surprising to me actually is how much the Libre 2 sensors, there's been a lot of iterative development on the issues they had in the hypoglycemia range, but how much they fell within zone A. We had 716 or 713 paired values there. Mindy is one of our pediatric endocrinology fellows. She's actually working on writing this data up, hopefully out after ADA. And then she's also taking this protocol and similarly doing, we're working together to make this move through the pediatrics hospital, Lucille Packard. Interesting considerations in pediatrics hospital because your patient, putting the device ownership and the requirements on your patient is not necessarily appropriate because they're not always the decision maker. So it's a little bit more of a challenge. Okay, so future directions. Oh, go fast. Okay, so randomized control trials of inpatient AID, yes, but simply meeting glycemic targets in inpatient AID trials will not guarantee widespread adoption in hospitals. Average lag time between research evidence and incorporation into clinical practice is 17 years. Therefore, the overall quote-unquote effectiveness of inpatient AID will not only depend on achieving glycemic outcomes, but also on feasibility and the success of implementation in practice. So this is partly what I based my K23 on, is generating foundational data on the potential and limitations of AID systems And then creating critical infrastructure on which future AID trials can be built, and also to support patients with who are trying to use AID in the hospital. Even though they're using it, we still put way too much on them in terms of requirements for use. So the concept is there's going to be an observational study evaluating the effectiveness of current systems and injections in patients with type 1 diabetes. Interestingly, like I alluded to, type 1 diabetes is very, very understudied in the inpatient environment. And those of us in that clinical practice are, I mean, it's a striking difference. I'm going to do some interviews to systematically identify barriers and facilitators, and then develop some implementation strategies to create essentially a implementation manual for incorporating this into inpatient care.
You should do a cost effectiveness study also. May have to model it.
I would be interested to, in your opinion, about what timing to do that with, because the cost effectiveness of, I mean, I guess because using like sort of commercially available AID systems.
I mean, it depends on what perspective. If it's a health system perspective, then you can do it in a narrower, shorter timeline.
Like if it's cost effective
For the system.
just even to allow the system.
Yes,
Yeah.
the insurer and to the system.
Yeah, that's a good point.
That would be an easy one to do.
Yeah. Good. Well, I know how to call.
Oh, not me.
So this will be the first one to use CGM to assess real-world inpatient AID use. I should put an asterisk here. There was actually a paper published not too long ago with some real-world AID use, 670G and 780G, but it was like 14 patients, so not a whole lot of data there. And then directly compare inpatient versus outpatient glycemic control, and examining the inpatient environment for diabetes device use, and then actually just evaluating glycemic control among inpatients with type 1 diabetes. We're also doing a study looking at device placement in the operating room with some collaborators. Actually, Vikram is a cardiovascular anesthesiologist who reached out to me about that interest, and Jack Boyd, farthest to the right, is a cardiovascular surgeon who has a lot of interest in this. All of our patients who go through cardiac surgery are on insulin drip, whether they have diabetes or not, and a lot are coming in on CGMs, and so there was a consideration about whether those can and cannot be used, and utility of APGs. Anyway, this should be interesting. Okay, so in summary, standard inpatient diabetes management strategies are, I would say, are actually still inadequate for our patients. We're not achieving targets. CGM is feasible, but the efficacy is limited maybe to subsets of the population, but because of those data utilization issues I mentioned before. AID may optimize the data you receive through the CGM, and hopefully providing some solution to that issue. And then, the demand is there, including for insulin dosing. I think that's what that survey data kind of shows. So we should be considering how to support this even better for our patients, including who's going to be responsible for what, how that responsibility can shift further away from patients, I think, to a certain extent, but also understanding the interests of all the stakeholders, like you just mentioned about cost effectiveness. And then, most of all, I think AID represents a significant opportunity for a paradigm shift in inpatient diabetes care, and we should understand these needs better so we can better tailor it to that environment. Ultimately, I don't think the solution is commercial outpatient systems in the inpatient environment. I think it's understanding that the inpatient environment is different. Insulin sensitivity changes in a different way. Nutrition changes in a different way. Activity levels are completely affected. And so algorithms need to be more adaptive. And that's what I think, that's what I hope this foundational data sort of shows, is that this is a step in the right direction, but we need to innovate in that space just as much as we've done in the outpatient space. Thank you. I don't know if it's post-pandemic or whatever, but I tend to like faces. So, on the top is, Bruce Buckingham and Rehan Lal, who I went out to Stanford to work with on diabetes technologies, and they've just been amazing, mentors to me. Some other folks, at Stanford, mentors. And then, I blew up these faces because, you guys know these guys, and, I just couldn't, thank, Francisco and Georgia and Guillermo enough for the, generous time that they've donated my direction in conversations and mentorship in different ways. So anyway, oh, and my wife and daughter, nothing happens without these guys. So, okay, thank you.